Hello, my name is Damian Engel, and I'm the co-founder and director of digital accessibility at Accessitree. I'm thrilled to have you here today for our webinar, A Colorado Healthcare Provider's Guide to the New HHS Digital Accessibility Rules. Thank you for taking the time out of your busy schedules to focus on this important topic. Over the next 30 minutes, we're going to unpack a landmark shift in healthcare regulation that impacts every one of you in this room and watching online. My goal today is not to scare you with legal jargon, but to provide you with a clear, practical roadmap to navigate what's ahead. We'll start by breaking down the new federal rule, what it is, who it applies to, and when you need to comply. Then, we'll demystify the technical standards and define what genuine accessibility actually looks like. We'll spend some critical time on a dangerous trend, so-called quick fix widgets, and I'll show you why they create more problems than they solve. After that, we'll look at the real-world costs of non-compliance versus the significant return on investing in access. I'll then provide you with a concrete roadmap, including average timelines, to help you start planning. We'll wrap up with 3 simple steps you can take next week to begin your journey. The core takeaway I want you to leave with today is this. This isn't just about compliance. It's about providing better care to a significant portion of our Colorado community and protecting your organization from very real legal and financial risks. Let's begin. What we're discussing today is a landmark shift in civil rights legislation. On May 9, 2024, the U.S. Department of Health and Human Services, or HHS, published a final rule that completely modernizes Section 504 of the Rehabilitation Act of 1973. This was the first full rewrite of these regulations in almost 50 years, bringing them into the digital age. The purpose of this rule is to strengthen and clarify non-discrimination protections for people with disabilities across every single program or activity that receives any federal funding from HHS. This is a powerful, sweeping update designed to ensure equity in healthcare. So let's break down exactly what this means for you. First, who is covered? The rule applies to any recipient of federal financial assistance from HHS. Let's translate that. If your organization accepts Medicare or Medicaid or government grants, you are covered. This isn't limited to large hospitals, it includes rural clinics, national insurers, dental and vision providers, and even assisted living facilities. The scope is incredibly broad. Second, what is required? The language is specific and unambiguous. All of your patient-facing digital content and mobile applications must conform to the Web Content Accessibility Guidelines, version 2.1, at the Level A and Level AA success criteria. We'll unpack what WCAG 2.1 AA means in the next section, but for now, know that this is the specific, testable standard you will be held to. And third, when is the deadline? For any organization with 15 or more employees, the compliance deadline is May 11, 2026. For smaller organizations with fewer than 15 employees, the deadline is 1 year later in May of 2027. While May 2026 may seem like it's a long way off, the journey to full compliance is a marathon, not a sprint. As we'll discuss, the process can take many months and the clock is already ticking. This isn't an abstract federal issue happening somewhere else. This has a direct and profound impact right here in our communities. In Colorado, there are over 600,000 people living with a disability. Let's make those numbers more tangible. That means nearly 5% of our state's population, 1 in 20 people, has a cognitive difficulty. Another 5% have a mobility difficulty. Over 3% have a hearing difficulty, and 2% have a vision difficulty. These are our neighbors, our family members, and most importantly, they are your patients. They are the people who rely on your websites to find a doctor, on your portals to check lab results, and on your media to learn about a procedure. There's a point of pride here as well. In early 2025, a study ranked Colorado as the #1 state in the nation for people with disabilities, citing our commitment to inclusivity, healthcare access, and community resources. This new HHS rule is our mandate to ensure that our digital front door, the primary way many patients now interact with you, lives up to that standard of excellence. It's a call to lead, not just to comply. It is absolutely critical for healthcare leadership to understand that this new rule is not just a technical checklist for your IT department. The digital accessibility requirement is one piece of a much larger, more comprehensive patient equity initiative from HHS. The same final rule that mandates WCAG 2.1 conformance also includes powerful new provisions to combat other forms of discrimination. For example, the rule explicitly prohibits medical treatment decisions based on biases or stereotypes about people with disabilities, such as denying an organ transplant to someone with an intellectual disability based on a false assumption that they couldn't manage postoperative care. It addresses the discriminatory use of value assessment methods that might place a lower value on extending the life of a person with a disability. It even mandates that, within 2 years, providers must have accessible medical equipment like height adjustable exam tables and weight scales that can accommodate wheelchairs. When you view the digital mandate within this broader context, the intention of the regulators becomes crystal clear. They view your website, your mobile app, your online documents, your media, and your patient portals as an integral, non-negotiable part of the total patient care experience. An inaccessible patient portal that prevents a patient who is blind from independently accessing their lab results is seen in the same light as a clinic with no wheelchair ramp. A recorded video without captions is viewed as a fundamental barrier to care, just like medical equipment that a patient cannot physically use. This means that a failure in digital accessibility won't be seen by the HHS Office for Civil Rights as a simple website error. It could be interpreted as evidence of a systemic failure to prioritize the needs of patients with disabilities, potentially linking it to other forms of discrimination within your organization. This is why this initiative cannot be delegated solely to your IT or marketing department. It requires engaged leadership from your compliance, patient experience, legal, and executive teams to ensure that digital equity is woven into the fabric of your organization's mission. So the law says you need to conform to WCAG 2.1 Level AA. For many of you, that might sound like technical jargon. Let's break it down into plain language. WCAG stands for the Web Content Accessibility Guidelines. It's the global gold standard for making digital content accessible to people with disabilities. It was created and is maintained by the World Wide Web Consortium, or W3C, the main international standards organization for the Internet. Think of it as the building code for the web. It provides a single, shared standard with testable criteria that organizations and governments around the world can use to ensure access for all. The HHS rule specifically mandates WCAG 2.1, which was released in 2018. It's important to note that a newer version, WCAG 2.2, was released in October 2023, while 2.1 is the legal minimum you must meet. Adopting the newer 2.2 standard now is a smart business decision. It will save you time and money on future retrofits and better future-proof your digital assets. To make WCAG easier to understand, the guidelines are organized around 4 core principles. You can remember them with the acronym POUR. For your content to be accessible, it must be perceivable, operable, understandable, and robust. Let's look at each one through the lens of a healthcare provider. First, perceivable. This principle states that information and user interface components must be presentable to users in ways they can perceive. In other words, the information can't be invisible to all of a person's senses. A perfect healthcare example is a video on your website that explains a complex medical procedure. For a patient who is deaf or hard of hearing, that video is useless without captions to convey the audio information. Similarly, if you post an infographic showing the location of a new clinic, a patient who is blind needs a text alternative, often called alt text, that describes the information in the image so their screen reader can announce it to them. It's about ensuring that no one is locked out of information because it's only presented in a single sensory format. Second, operable. This means that users must be able to operate the interface. The interface cannot require an interaction that a user is physically unable to perform. Think about a patient with severe arthritis or hand tremors from a condition like Parkinson's disease. Using a mouse with precision can be difficult or impossible. For them to book an appointment online, they must be able to navigate your website or patient portal using only their keyboard, tabbing from link to link, pressing enter to make a selection, and filling out forms without ever touching a mouse. Another aspect of operability is avoiding content that can cause physical harm, such as flashing animations that could trigger seizures. Third, understandable. This principle is about clarity and predictability. Information and the operation of the interface must be easy to comprehend. This is incredibly relevant in healthcare. Consider a patient undergoing chemotherapy who is experiencing what is often called chemo brain, a cognitive fog that can make complex information overwhelming. If they visit your website to pay a bill, is the layout consistent and predictable? Are the instructions written in simple, plain language? When they make a mistake filling out a form, are the error messages helpful and clear about how to fix the problem? Understandability is about reducing cognitive load for everyone, especially those who may be stressed, sick, or experiencing cognitive challenges. Finally, robust. This means your content must be robust enough that it can be interpreted reliably by a wide variety of user agents, including assistive technologies, both now and in the future. This is the most technical of the four principles, but the concept is simple. Your digital assets need to be well built. It's about using clean, standard compliant code so that it plays nicely with the technologies your patients use. For example, a patient who is blind uses software called a screen reader that reads the content of a web page aloud. If your website's code is sloppy or non-standard, the screen reader might misinterpret a dosage for a medication, skip over an important allergy warning, or crash altogether. Robustness ensures that as technology evolves, your content remains accessible. So, what does poor look like in practice across your digital ecosystem? On your websites, it means having high color contrast between text and backgrounds, ensuring all functions can be accessed with a keyboard, and using proper heading structures so a screen reader user can easily scan the page. In your patient portals, it means forms for prescription refills are properly labeled, error messages are clear and helpful, and a patient can use their screen reader to independently access sensitive lab results or communicate with their doctor. For your media, this means providing synchronized, accurate captions for all pre-recorded videos that have audio. If a video has important visual information that isn't described in the audio, like on-screen text, it must also have an audio description. For audio-only content, such as podcasts, you should provide an accurate transcript. Even for kiosks and tablets in your waiting rooms, the principles apply. While the HHS rule doesn't set a specific technical standard for kiosks yet, it suggests applying WCAG principles to the software. And crucially, the rule states that any workaround you provide, like asking a patient who can't use the kiosks or tablets to go to the front desk, must offer the same access, convenience, and confidentiality. Real accessibility is not a single feature. It's the result of thoughtful design and development woven into every digital touchpoint you have with your patients. Now I need to address a critical and dangerous trend in the world of digital accessibility. As awareness of these legal requirements has grown, a cottage industry of products has emerged, promising a quick, cheap, and easy solution. You've likely seen them, a small icon, often shaped like a person, that sits in the corner of a website. When you click it, a toolbar opens with options to change colors or text size. These are called accessibility overlays or widgets. They are marketed aggressively, often using AI as a buzzword, and they all make the same seductive promise. Add one line of code to your website, and you will be instantly compliant with the law and protected from lawsuits. It sounds too good to be true, and I'm here to tell you that it absolutely is. The central technical failing of every overlay on the market is that it cannot alter your website's underlying source code. These tools use JavaScript to apply a temporary, superficial layer of fixes over your existing site structure within the user's browser. Worse than being ineffective, these overlays frequently make websites less accessible. They often conflict with the very assistive technologies, like screen readers, that people with disabilities have spent years mastering and customizing to their specific needs. A user with a disability already has tools on their computer or in their browser to adjust text size or change colors. The overlay's features are, at best, redundant. At worst, the overlay hijacks their keyboard controls, clutters the page with confusing announcements, and creates a frustrating, unusable experience. The disability community has been overwhelmingly vocal in its rejection of these tools. When the supposed fix makes a website unusable even for an expert, you know there is a fundamental problem. For years, the argument against overlays was that they were simply ineffective, but the landscape has shifted dramatically. The presence of an overlay on your website is no longer a neutral factor. It is now being used as evidence against companies in court. Let me be very clear about this, because it is the single most important thing you need to understand about this topic. According to a 2024 report on digital accessibility lawsuits, 25% of all lawsuits were filed against websites that were using an accessibility overlay. Plaintiffs are no longer just suing inaccessible websites that happen to have an overlay. Their legal complaints are now specifically citing the overlay itself as a barrier to access. The legal and regulatory environment has turned decisively against these products. In early 2025, the Federal Trade Commission, the FTC, fined a major overlay company for false advertising and misleading claims about its capabilities. Major advocacy organizations, like the National Federation of the Blind, have publicly condemned and even banned these companies from their national conventions. This represents a fundamental change. The legal argument that an overlay constitutes a good faith effort to comply with the law has been completely dismantled. Installing one of these widgets is now a documented, legally recognized misstep that demonstrates a fundamental misunderstanding of what digital accessibility requires. Far from reducing your risk, it can paint a target on your back for litigation, signaling to plaintiffs' attorneys that you are aware of the issue but have chosen an inadequate and harmful solution. Understanding the risks of overlays leads us to the broader question of the cost of inaction. Failing to comply with the new HHS rule and other accessibility laws like the Americans with Disabilities Act carries significant and multifaceted risks. First, there are the direct financial penalties. While the HHS rule is new, we can look to the enforcement of the ADA for guidance. Under the ADA, the Department of Justice can levy civil penalties of up to $75,000 for a first violation and $150,000 for each subsequent violation. Beyond federal fines, you face the high cost of private litigation. Defending against an accessibility lawsuit is incredibly expensive. Even if you settle quickly, you will likely be responsible for the plaintiff's legal fees, which can run into the tens of thousands of dollars, on top of your own attorney's fees, which one expert conservatively estimates at $5,000 to $15,000 just to get started. Under Colorado House Bill 21-1110, it is a state civil rights violation for a government-led entity to exclude people with disabilities due to a lack of accessibility. This law empowers individuals with disabilities to sue non-compliant entities in state court. If found liable, your organization could be ordered to pay a statutory fine of $3,500 per violation to the plaintiff, in addition to actual monetary damages and attorney's fees, which can quickly escalate the cost. Perhaps the most significant cost, especially in healthcare, is the damage to your brand and reputation. Trust is the currency of healthcare. A lawsuit or even a public complaint about your digital services being inaccessible to patients with disabilities sends a powerful and damaging message. It suggests that your organization is not inclusive, not patient-centered, and is failing a vulnerable segment of the community you serve. Now let's flip the coin and talk about the return on investing in authentic accessibility. This is not just an expense to mitigate risk, it is an investment in a better healthcare organization. First and foremost, you expand your patient reach. By making your digital services fully accessible, you are explicitly opening your doors to the more than 664,000 Coloradans with disabilities, along with their families and caregivers who help them manage their health. This is a significant and often underserved market. Second, you improve the patient experience for everyone. The principles of accessible design are the principles of good design, features that are essential for users with disabilities, like clear and simple language, predictable navigation, and helpful error messages. Improve the usability of your digital platforms for all of your patients. This includes older adults who may be less tech savvy, someone with a temporary injury like a broken arm trying to navigate with one hand, or any patient who is feeling stressed, sick, and overwhelmed. Finally, this investment can lead to tangible operational efficiencies and revenue growth. This isn't just a theory. We have real-world examples from the healthcare sector. WakeMed Health and Hospitals in North Carolina embarked on a major initiative to improve patient access. A key part of their strategy was patient access, which resulted in an 81.6% increase in patients directly scheduling appointments through their patient portal. The outcome? In just 1 year, they saw a $25.4 million increase in revenue, which they attributed in part to a nearly 16% rise in outpatient visits. Another powerful example is CVS Health. They recognize that accessibility is a business and ethical imperative in healthcare. They made a strategic decision to scale their internal accessibility department from just 4 people to over 100, intentionally hiring professionals with disabilities to ensure they were building solutions with the community, not just for them. This level of commitment demonstrates how industry leaders are moving beyond mere compliance to embed accessibility into their core strategy. So, how do you get there? The most effective way to approach the May 2026 deadline is to stop thinking of this as a single project. To be successful, you must conceptualize and manage this as a comprehensive program with at least 3 distinct parallel work streams running concurrently: your interactive platforms, your document library, and your multimedia content. Each of these has its own unique process, timeline, and budget considerations. A plan that only accounts for your main website will fail because it ignores the vast universe of PDFs and videos that most healthcare organizations possess. The first work stream is the most complex and is typically where organizations start. It covers your public-facing website, your secure patient portal, and any mobile apps you offer. The process generally follows 4 key phases. Phase 1, inventory and triage. The first step is to map out every patient-facing digital asset you own. You can't fix what you don't know you have. Once you have your list, you must prioritize, focusing on the most critical and high-traffic areas first, like your appointment scheduling workflow or your bill pay function. Phase 2, audit. This is the cornerstone of your entire program. A comprehensive accessibility audit involves a combination of automated scanning and, most importantly, manual testing by experts. This is not a simple scan. It involves trained professionals attempting to use your site with a keyboard alone and with screen reader software, just as a patient with a disability would. The output is a detailed report that lists every violation and provides guidance for remediation. Phase 3, remediate. This is the phase where your development team, or a specialized partner like Accessitree, gets to work fixing the code and design issues identified in the audit report. And Phase 4, validate. After the fixes are implemented, a second round of manual testing is conducted to verify that the issues have been resolved correctly and that no new problems were introduced. Now let's talk about timelines. Based on industry data for a small to medium-sized website, this entire 4-phase process typically takes 2 to 6 months to complete. For a large, complex hospital system with an integrated patient portal and mobile apps, this can easily extend to 12 months or much longer. And it's critical to remember that this timeline only starts after you've selected a partner. The procurement process itself, getting quotes, legal reviews, and contract approvals, can add another 2 to 3 months before any auditing work even begins. So, a realistic end-to-end timeline from decision to completion can easily be 7 months or more. The second major work stream is your library of digital documents, which, for most healthcare organizations, means an enormous number of PDFs. Think of every patient intake form, informational brochure, explanation of benefits, and research paper you have available for download. Under the new rule, any of these documents used by patients must be accessible. The challenge here is one of scale. A large health system can have thousands of these documents living on its website. The process for making a PDF accessible is a specialized skill. It involves adding a tag structure to the document that defines the reading order and identifies elements like headings, paragraphs, lists, and tables so that a screen reader can navigate it logically. Given the potential volume, this is often a long-term project that can take several months or even longer to complete. The good news is that this work can be done in batches. A typical turnaround time from a professional remediation service for a single batch of documents is about 5 business days. The key is to develop a systematic plan to inventory, prioritize, and remediate your documents over time. The third work stream covers your multimedia content. This includes any pre-recorded videos on your website or social media channels, such as patient testimonials, physician interviews, or instructional videos. The requirements here are very specific. All pre-recorded videos with audio must have synchronized, accurate captions, and the option to display a transcript. If the video contains important information that is only presented visually, for example, text on a slide or a key action that isn't described in the dialogue, it must also have an audio description. Audio descriptions are a separate audio track where a narrator describes the key visual elements. The timeline for this work is typically on a per-file basis. Professional, human-verified captioning for a video usually has a standard turnaround time of 2 to 4 days. Audio description is a more intensive process and can take longer, often around 5 to 7 business days per video file. Finally, it's crucial to understand that remediation is not the end of the journey. The goal is to build a sustainable accessibility program so that you don't find yourself in this same position a few years from now. This involves 2 key long-term strategies. First, update your vendor contracts. The HHS rule makes it clear that you are responsible for the accessibility of third-party tools and platforms that you use to serve patients. You must update your contracts to require WCAG 2.1 AA conformance from all of your digital vendors, from your patient portal provider to your scheduling software, and you must demand proof of their conformance. Second, you must embed accessibility into your internal workflows. Accessibility needs to become part of your organization's DNA. This means incorporating it into your procurement processes, your quality assurance testing, your content creation guidelines, and providing ongoing training for your staff. By making accessibility a standard part of how you operate, you prevent new barriers from being created and ensure long-term, sustainable compliance. I know this is a lot of information and it can feel overwhelming, but you don't have to solve everything overnight. The journey to compliance starts with a few simple, concrete steps. Step 1. Designate a leader. Go back to your organization and identify a single person or a small cross-functional committee to own this initiative. This cannot be an orphan project that falls between the cracks of different departments. It needs a clear owner who is empowered to drive it forward. Step 2. Start your inventory. Begin the process of mapping every patient-facing digital asset you have. Start simple. What is your main website address? Do you have a mobile app? What is the link to your patient portal? What are the top 20 most visited pages or downloaded patient forms on your site? You can't scope the problem or build a budget until you know what you have. Step 3. Schedule a professional audit. This is the single most important and impactful next step you can take. A professional manual accessibility audit will give you a clear, objective baseline of where you stand today. It will move you from the unknown to the known. The audit report will become the foundation of your entire compliance strategy, providing you with a concrete, actionable list of issues to address. At Accessitree, this is precisely what we do. We specialize in helping healthcare organizations like yours navigate this complex process. From providing the comprehensive inventory and priority assignments that form the foundation of your strategy, to performing the hands-on technical remediation, to helping you consult with your vendors, our entire focus is on being a dedicated partner to the healthcare community on this journey to digital inclusion. Thank you for your time and attention today. I hope this has provided you with a clear and valuable framework for understanding the new HHS rule and the path to compliance and inclusion.